So that's the title of my talk. And why is understanding morphology so important? Because I think it helps in making an accurate diagnosis, planning a management strategy, and in many patients, even in prognostication. So as you know, tetralogy of Fallot comprises of 4 components, namely the VSD, the right ventricular outflow tract obstruction, aortic override, and right ventricular hypertrophy, of which first 2 are the primary defects comprising VSD and RVOT obstruction, and the subsequent 2 are just the outcomes of the first 2 morphological abnormalities. So when it comes to morphological description of tetralogy, I think I would like to deal with ventricular septal defect, right ventricular outflow tract obstruction, status of pulmonary arteries, more so in relationship to tetralogy of Fallot with pulmonary atresia, and maybe touch upon some associated anomalies. So VSD in tetralogy is described in many ways. Some call it subaortic, some others perimembranous, conoventricular, or malaligned. Physiologically, most of these defects are large and non-restrictive. And when you say large, at least as large or larger than the aortic root, and non-restrictive physiologically means that the pressures on either sides of the septum are equal. So this is a cartoon which will show you in normal heart how the septum looks like. That's the muscular outlet septum. That's the ventriculoinfundibular fold. And in tetralogy of Fallot, the outlet septum tends to go superiorly and anteriorly. So many of the morphologists call it a monology because the outlet septum has come out of its usual position, has moved anteriorly and superiorly, causing a VSD at this level and right ventricular outflow tract obstruction higher up. So this is in real heart. You can see the V, the 2 limbs of trabeculoseptomarginalis, and you can see that the outlet septum from here has moved anteriorly, and you can see how it causes narrowing at the level of the os infundibulum. And this is where what Songo showed you just now, that is where the conduction system runs along the posterior and inferior part of the VSD and is therefore liable to injury when you are dealing with that part of ventricular septal defect. So these are some of the VSD variations. Although rare, one should be aware of it. There could be complete absence of outlet septum when VSD can extend right up to the pulmonary annulus. And in these cases, usually the obstruction is at the annular and the valvar level and may extend even beyond that. Sometimes tetralogy may be associated with AV septal defect. There could be additional muscular VSDs, and as you know, clinically quite difficult to pick up preoperatively in some patients because of equalization of pressures on both sides, and then you get aware of them only postoperatively when it gets difficult to extubate the patient because of hemodynamic significance of these VSDs. And still very rarely you can have restriction of the ventricular septal defect by various mechanisms, and one of those mechanisms I'm going to show you in my specimens. As far as the right ventricular outflow tract obstruction is concerned, it can be isolated in the subvalvar region. That's the hallmark of tetralogy. But more often than not, it's at multiple levels, subvalvar, valvar, and maybe even supravalvar, extending into the pulmonary artery branches. As far as isolated subvalvar obstruction is concerned, I think it's amenable to transatrial repair. Most of these patients don't require a transannular patch, and hence no hassles about long-term free pulmonary regurgitation. So redo is quite uncommon in this subset of patients. As against that, when you have multiple levels of obstruction, I think many of them will need a transannular patch extending over the MP and sometimes into the branches. So implications in terms of long-standing pulmonary regurgitation and recurrence of branch pulmonary artery stenosis. As far as tetralogy of Fallot with pulmonary atresia is concerned, I think there are 2 issues which the surgeons would always like to know. One is about the pulmonary arteries, and second is about the pulmonary blood flow. Pulmonary arteries, the 3 features that you need to know when you are describing the morphology to the surgeon is whether they are confluent or non-confluent, whether the central pulmonary arteries are present or absent, and if they are present, are they hypoplastic, and what's the severity severity of hypoplasia, because this is what is going to determine the management strategy for these patients. Apart from pulmonary arteries, I think it's essential that you know about the pulmonary blood flow, whether it's unifocal or multifocal, and if it is multifocal, whether it is a dual supply or whether it's a single source of pulmonary blood flow. And this is a cartoon which will give you an idea about unifocal pulmonary blood supply, multifocal, but there is a dual supply, multifocal, but a non-dual supply. These are non-confluent central pulmonary arteries, and these are absent central pulmonary arteries. I think the most difficult subset to treat surgically. And these are some of the associated anomalies like left SVC draining into the coronary sinus, subaortic left innominate, very rarely total anomalous veins, right aortic arch, and coronary anomalies like LAD crossing the right ventricular outflow tract. And MAPCIS is more of a hallmark of tetralogy with pulmonary atresia, very uncommonly seen with tetralogy of Fallot. So in summary, tetralogy is a wide morphological spectrum. It has varied clinical presentations and prognosis because of variations in morphology. That's why it's difficult to formulate rules of management, and the approach necessarily needs to be individualized. And I'll show you some of the specimens that I have.
Hello friends, so this is the first specimen that I'm going to show you. I'm trying to show you the external appearance of the heart in cases of tetralogy of Fallot. So this is the right atrial appendage, you can see this. This is the right ventricle. And you can see this is the left anterior descending artery which separates the right ventricle from the left ventricle. Now you see the right ventricle is a dominant ventricle in tetralogy as compared to the left ventricle, which is much smaller. You can see the left atrial appendage here, and you can see the quadrangular shaped right atrial appendage here. Another characteristic of hearts with tetralogy is the discrepancy between the outflows of the right ventricle. You see how hypoplastic the main pulmonary artery is, and this is the aorta, and you can see that the aortic size is significantly larger because it takes a large amount of cardiac output because of pulmonary outflow tract obstruction. So this is the specimen of the heart which is of tetralogy of Fallot, and this is the opened up right atrium, and you can see the hypertrophy of the right atrial wall, and this is the stretched foraminal veil or a small secondum AST, and that's the tricuspid valve, and that's the right ventricular inflow, and you can see the hypertrophy of the right ventricle. The wall is significantly thickened. And then this is the characteristic of tetralogy. You can see that this is the ventricular septal defect here, which is located between the two limbs, the posterior inferior limb and the anterior superior limb of the trabeculoseptum marginalis. And this is the outflow septum. You can see this on the outlet septum, which is moved anteriorly and superiorly from its original position. It has come here, producing significant narrowing of the right ventricular outflow tract. If I were to close this, you will be able to appreciate that this would cause a severe narrowing of the right ventricular outflow tract. This portion where the narrowing of the outflow is maximum is referred to as the os infundibulum. And this is the pulmonary annulus here and the main pulmonary artery and its branches. Now we will see the left side of the heart. So this is the opened up left atrium with pulmonary veins along the posterior wall. This is the mitral valve. This is the left ventricle, and this is the left ventricular. This is the ventricular septal defect here, and you see this VSD. It lies exactly below the aortic valve, and that's why it is referred to as the subaortic VSD. And if you see, this part of the aorta is really committed to the right ventricle, and that is why this aorta is called as the overriding aorta, which overrides the interventricular septum. So this is a dilated right atrium, and you can see that there is a large secondum atrial septal defect here, And you can see that there is a displacement of the tricuspid valve leaflet. The septal leaflet of the tricuspid valve has moved down, and there is a complete tethering. I can't go underneath this septal leaflet of the tricuspid valve. So this is Epstein's malformation of the tricuspid valve, and it is associated with, you can see that there is a ventricular septal defect right here. Right here. Can you focus there? Yeah. So this is the ventricular septal defect. Again, characteristically lying between the anterior superior limb here and the posterior inferior limb of the trabeculoseptomarginalis. And you can see that this is the outlet septum, which is moved away from its normal position, causing narrowing of the right ventricular outflow tract. And one more characteristic, if you see this VSD, a part of this VSD is covered by the tricuspid valve leaflet, so making this VSD restricted. So this is a very unusual case of Epstein's anomaly with tetralogy with a VSD which is restricted.
So both the characteristics are quite unusual.
So
Epstein's as well as restrictive VSD.
Which is characterized by its typical ventricular septal defect, which you have seen in the earlier specimens as well, between the two limbs of trabeculoseptomarginalis. But the variation in this case is not pertaining to the VSD as you saw earlier, but it is pertaining to the right ventricular outflow tract. You can see this right ventricular outflow tract. The outlet septum is here, and it's almost fused with the right ventricular free wall, causing complete atresia of the right ventricular outflow tract. You can see this is completely atretic. Despite there being atresia, the main pulmonary artery and its branches are well formed. Probably this is the patient who had good-sized patent ductus arteriosus, resulting into well-formed pulmonary artery and branches. So this is a subset of patients who do very well with intracardiac repair because of good-sized and confident pulmonary arteries. So this is one more specimen of tetralogy of Fallot. You can see with its characteristic VSD two limbs of the V, which is formed by the two limbs of trabeculoseptomarginalis, and that's the ventricular septal defect. And the interesting part is that the outlet septum has moved from its original position, but not causing any significant outflow tract obstruction. And this is yet another variation in the outflow tract, which you can see here. The pulmonary valve is not well formed, almost absent, excepting for a tiny little nubbing here. The rest of the pulmonary valve is absent, and you can see it is characterized by significant dilatation of the main pulmonary artery as well as its branches, one going this way is the left pulmonary artery, and the other one which is going this way is the right pulmonary artery. So this is a case of tetralogy of Fallot with absent pulmonary valve. You can see this nubbings or dysplastic pulmonary valve tissue, which is here, but the rest of the pulmonary annulus is completely devoid of valvular tissue. So this is another case of tetralogy of Fallot with its characteristic VSD and the outflow septum having moved anteriorly and superiorly. The reason to show you this case is another variation in the right ventricular outflow tract. You can see that this is a case where there is a severe hypoplasia of the main pulmonary artery, which is opened up now. And these are the two branches, the left pulmonary artery here and the right pulmonary artery here. So in the earlier case, you saw that the pulmonary arteries were reasonably well formed. As against this, in this particular case, the pulmonary arteries are severely hypoplastic. So you can have variations in the ventricular septal defect, you can have variations in the right ventricular outflow tract in terms of its stenosis, the length of stenosis, the severity of stenosis, and of course the hypoplasia of the pulmonary arteries. And all these variations will decide the clinical presentation, the prognosis, and the management strategy. Thank you.
Okay, thank you.